Dr. Jesse Mills, the director of the men's clinic at UCLA Health, professor of urology at the David Geffen School of Medicine at UCLA, author of the Field Guide to Men's Health, and delighted to be here talking with you about Peyronie's disease. We have no idea. The answer to what causes Peyronie's disease it's a question that's gone back for centuries because we've known about it. It's been described for over 300 years. We think it's probably a combination of genetic factors and then some sort of injury to the penis, or what we call microtrauma, where maybe repetitive injury with not a fully erect penis causes scar tissue to form, and then that causes the curvature. But it's a multi-step, very complicated process. And one of the things I like to tell my patients is, nothing you did to your penis caused this. This is all something that happens. It was probably woven into your genes. The goal is not what caused it, but how we're going to make you better. Non-surgical treatments for Peyronie's are really one. I mean, there's one FDA-approved therapy, which is Xiaflex or collagenase, and it has been FDA-approved for over 10 years. So that would be considered the gold standard for non-surgical therapy. There are pills, there are supplements, there are creams. All of these things have limited to no efficacy at all. In fact, some of them probably cause more harm than good that I tell patients to avoid. But if you get down to it, really there's one thing that has proven efficacy, and that is intralesional therapy. In the intralesional therapy, there's really three things. There's the collagenase, which we talked about, or Xiaflex, and that truly has been the market leader with proven efficacy, more publications on this than anything else. And then over the past few years, or over the past before Xiaflex years, there was intralesional verapamil, which showed modest to minimal efficacy, and then even injections of interferon into the plaque. That's really the trifecta of injectable therapies that show any improvement in Peyronie's disease. There's also a little bit of literature around doing some kind of mechanical traction therapy to the penis, and usually in combination with Xiaflex or an intralesional injection. And then lastly, there certainly are some therapies that are not FDA approved that have had some degree of scrutiny. One is injection of either stem cells or PRP, or platelet-rich plasma. And then finally, even shockwave therapy, which is used and somewhat standard of care for mild erectile dysfunction, shows a little bit of efficacy for improving the pain symptoms of Peyronie's disease. But outside of that, it really rolls back to the fact that there's one proven therapy that has FDA approval, and that's Xiaflex. Surgery is the best option when you have a conversation with your patient about what the options are. And I like to say that the penis decides the treatment, not the patient, not the physician. Because in fact, sometimes there are men that come in with advanced, really devastating Peyronie's disease, a very large plaque burden that intralesional therapy would not be as effective for men that have calcified plaques that don't also respond to intralesional therapy. Then I start talking about surgery, and then there are also people that want to just get fixed, that want to have a relatively straightforward outpatient surgery that will give them durational therapy without the long-term follow-up needed for the intralesional route. But ultimately it comes down to a very detailed conversation with the patient about what his risk factors are for surgery and what his expected outcomes would be if he decided to do surgery as opposed to a less invasive option. So if Peyronie's disease goes untreated, it is not a fatal disease, but the longer a man has Peyronie's disease, the longer he suffers from it. And so I would say the risks are twofold. One, it may make ultimate therapy more difficult, but two, it causes a lot of emotional trauma and psychological trauma. The longer a man deals with something that can completely change the way he interacts with his partner, it can completely change the way that the outcome will look. So in other words, there are men that have dealt with this for years, and one of the first things I ask my patients is, what brought you in today? What brought you into my office today? There are men that have had this for 10 years, and finally something triggered them to come in. There are men that have had it for 3 days, and they've read all they could about it and got in as soon as they can. So I have to meet patients where they're at and say, here's the deal. You're here today. If we don't do anything, then this could progress. Rarely it stays the same, and even less often it actually goes away on its own. So the goal for me is to intervene early because the outcomes are better. men will get treated sooner and they will get back to a normal life even quicker than if they waited. So if a man undergoes an operation for Peyronie's, there's really 3 different operations. The probably most straightforward and the quickest recovery is some form of a penile plication, where it's literally just straightening the penis, correcting that curvature with a few well-placed sutures. That's something that procedurally takes somewhere between an hour and an hour and a half, and recovery is about 3 to 4 weeks before they can get back to full activity. No real activity restrictions for exercise. We'll have no difficulty urinating after the surgery, but certainly refraining from sexual intercourse until the incision heals, which is again about 3 to 4 weeks. The complexity goes up from there. The more invasive surgery will take a little bit longer to heal, which is a plaque excision and graft, followed by a penile implant, which is also a good operation for men that have severe Peyronie's disease and severe erectile dysfunction. But ultimately the recovery will depend on what surgical output or outlet they choose, but anywhere from 3 weeks to about 6 weeks is a common way for men to frame how they're going to recover from a surgical intervention. So the only treatment that reverses curvature that is non-surgical would be intralesional injection, and that has shown very good track record with variable results depending on publications, but anywhere from 30 up to even 60% improvement in curvature with injection therapy. That's about the best way I can say to reverse curvature with minimal side effects if a patient is a good candidate for intralesional therapy. Reversing curvature through surgery can be very, very gratifying, can be very effective, but there still is a recidivism rate. There are some men that will continue to develop curvature even after surgery, or some men that won't even respond to surgical intervention. So my goal is to really couch patients, teach them that your expectations are going to be what they are for you, manage them appropriately, and make sure that we always have the open door for them to come back for any additional therapies they might need to get the outcome they want. You know, the satisfaction of Peyronie's surgery outcome is purely based on how good of a conversation you have as a surgeon or as a clinician with that patient. So the most satisfying outcomes are the one where you tell patients, here's how things will go, here's how we want them to go, but let's meet each other where we're at, because one of the highest population is dissatisfied, or men that are told that they're going to have the penis they had prior to developing Peyronie's disease, because that man doesn't exist. Once a man develops Peyronie's disease, the best we can do is get them back to a functional penis. So the best outcome that I would tell somebody is, wherever you're at now, my goal is to make you functional again. Cosmetically, you may not be satisfied. You may be satisfied. That would be an ideal outcome. But fundamentally, we're going to take you where you are now, which is not functional, and return functionality so that you can have as normal penetrative intercourse as we would hope. Well, it happens that we're recording this on Peyronie's National Awareness Day, and so I think the most important thing that gets a little bit lost, especially in the urology community where we are taught to treat patients for physical ailments and we have a surgical bend, is the mental health impact of Peyronie's disease. I think is one of the most critical aspects of dealing with these men. As a provider, if you're not willing or you're not able to recognize how devastating this condition can be to people, and we have good data, some of my own publications showing the rate of men that are on antidepressant therapy, the rate of men that consider or even follow through with suicide because of their Peyronie's disease is 2 to 3-fold higher than the general population. So let's keep in mind that we're treating the whole patient. We're not just treating his penis.